Hello, can you hear me now?
Much better.
Okay. I'm just going to introduce Dr. Qhama. Today we have Dr. Qhama from Medical Science School Field. So I'll just say welcome, Dr. Qhama, to our seminar. You are in the group of UNISA, the Center of Astrophysics and Space Sciences. So I thought maybe it will be good just to give a brief what is astrophysics and space sciences. So it's a field that studies like a universe, space, and the physics processes that govern them. And it combines like physics, maths, and observations to understand like how the star forms or like a galactic how they are formed and how they evolved. Actually, we also include like one of our own galaxy that I hope you know it. It's called Milky Way. And we also have like astrophysics mazes and how the universe itself form or evolve or interact. So I hope that your presentation is quite accessible to us because we are not medical science school. So here on this group, like we have masters, PhDs, and postdocs, professors. So yeah, I think I'll just have to read your bibliography and you will take us through your presentation. So everyone, bibliography by Dr. Qhama. Dr. Qhama is a specialist psychiatrist with 6 years of experience in clinical practice, academic psychiatry, clinical leadership, psycho therapy informed care, and medical education. He has held senior clinical and teaching roles at Wilkenberg Hospital and the University of Cape Town. And his qualifications, medical degree, basically he is a qualified medical doctor, FC, a psych SA, which is a fellowship in psychiatry from the College of Psychiatrists of South Africa, and also a Master of Philosophy degree from UCT, and also a Master of Science related to health, economics, and policy management from the London School of Economics. I hope I'm correct there, Doctor. And also we have DMH SA, a qualification related to medical health and a psychiatry in South Africa. So, and there is a PG DIP HSE, a postgraduate diploma related to health sciences education from UCT. So welcome, Doctor, to our seminar. Now you can take us through your presentation.
Sure. Pauline, thank you for the introduction. I, 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 I don't think you should have told me what you guys do, because now I'm really anxious, and I hope I don't become too anxious and overwhelmed. Um, okay, so I don't have many slides prepared because I thought that I wanted to leave quite a bit of time for a question answer session. Um, but essentially, as an introduction, I mean, I think you've kind of given a background to who I am and what I do. So I'm a psychiatrist, and in my clinical work, I enjoy working with young adults. That's students and university people where I'm based, as well as obviously professionals that are working. Um, I'm also a teacher and a researcher and an examiner, so I understand a little bit about the research and academic background. But I'm also a parent, and I'm a husband, and I've got a young family. So I'm in the daily hustle, and in that day-to-day groove where I'm running from place to place. So this topic that we're discussing today, the topic of stress, burnout, and depression, I think it's it's something that's close to my heart, and I want to commend you guys for having this forum and actually talking about this topic. Now, if you look at this picture here, the image, it's of a gremlin, and I don't know how many of you will remember the movie Gremlins from the 1980s. I mean, I remember it quite well. But for those of you who don't remember it, I want to summarize the movie in just in a short bit. So essentially, the movie is about this character, right? This creature that is a gremlin. It's not a gremlin. This creature is called Gizmo, right? And it's a cute, it's a cuddly creature, which it's energetic, it's nurturing, it's fun to be around. And so this parent sees this creature and wants to buy this creature for their child, and they go and they buy this creature for their child. But when they buy this creature, the person who's selling it to them keeps giving them these three strict instructions, and the instructions are make sure it doesn't get it doesn't get too much light, right? It's make sure the creature doesn't get wet, and it's make sure that you don't feed this creature after midnight. And the shopkeeper is quite insistent, do not break these rules. But as we all know, with rules get broken, and in the movie, over a series of events, each of these rules get broken, and to an extent where now this creature actually transforms and becomes this beast, and these many beasts that become ungovernable. So I think what makes me think around, when I think of stress, I think around gremlins, and the idea that stress on its own is not a problem, but unmanageable stress can certainly become a problem, and chronic stress can certainly become a problem. So, us as academics and us as people, it's the idea that, we shouldn't, well, for us, the blight is around us getting enough sleep. The idea that our body needs um, rest, and that our circadian systems around our body, are determined by light. And if we don't sleep well, we run into problems. That idea of getting this creature wet, it's around exposing one to chronic stress. And the idea is that, yes, stress can be useful, but if we're chronically stressed, at some point, we're not able to maintain it anymore. And the idea of not feeding after midnight, it's the idea that we should actually not become too self-indulgent on things that are short term and help us to cope in the short term. So, when we're stressed, we stop exercising, we start eating badly, we start self-medicating. So we drink a little bit more, we'll drink a whole lot more caffeine. Some of us might use gummies, and we self-medicate in all these different ways. And those different ways can actually lead us to having big problems. So, the idea is that it's not the stress that's the problem, it's the chronicity of the stress and not actually taking recovery. So there's three stages to stress, right? And stress, what stage one is healthy. What is healthy stress? Stage two would be when the stress becomes unhealthy and it can become burnout. And stage three is where psychiatrists like myself often need to get involved, where now it's actually diagnosable mental health illness. So, when we stressed, what happens is that our body adapts. So biologically, our bodies evolved over many years, and our body prioritizes survival over comfort. And we know that when there's a stress, automatically our amygdala fires off, and our amygdala communicates with our hypothalamus as well as our prefrontal cortex and hippocampus. And two kinds of things happen. There's a fight or flight response, and there's also signaling to our hypothalamus, pituitary, and adrenals, as well as the release of cortisol. So when we have a stress of any kind, something stressful, our, we get this shot of adrenaline. And what happens is our pupils get dilated, um, our heart rate goes up, our blood pressure goes up, our bronchi in our lungs inflate. And this idea is that we prepared, we're preparing for the stress. And in our body, our body doesn't differentiate between the kinds of stress. It just recognizes stress. So whether you are giving a lecture, whether you're presenting a paper somewhere, whether you're being examined by someone, or whether you're being chased by a lion, our brain releases this adrenaline, and our body responds to this adrenaline in a similar way. It's not only adrenaline that's released. We also there's a spike of cortisol that's released, and cortisol gets a bad name. We always talk about, it's just like cortisol release, but cortisol in short bursts is actually very useful. Cortisol in short bursts, what it does is that it allows us to mobilize glucose. It allows us to sustain attention. It allows us to actually maintain our energy levels. So cortisol in short bursts is useful. And the problem with cortisol, though, is that if it's chronically there, it can cause harm. Our body's other change is that we've got a part of our brain, which is the locus coeruleus, and with stress, we secrete noradrenaline as well. And the noradrenaline kind of, it helps us to increase the signal to noise ratio so that we can sharpen our attention and suppress irrelevant information. So it's the thinking that, it's the thinking that we, before a deadline, for example, the day before a deadline, we suddenly become able to focus and not be distracted by other things. If we have to do our data analysis before a certain date, the day before, the night before, we can be super sharp and not worry or focus on the other things that were distracting us before. And that's the noradrenaline that's being released. Um, with moderate stress, with the right enough level of stress, our prefrontal cortex is also stimulated. So our prefrontal cortex is the part of our brain that's involved with our function. So if you think of executives, what are they meant to do? So executives are meant to come up with ideas, generate ideas. They're meant to plan things. They're meant to monitor the implementation of things. They're meant to make judgments on complex decisions. And and executives often hold the working memory for the organization, and they do that for our brain as well. Our prefrontal cortex holds our working memory. So with the right level of stress, our prefrontal cortex is also um, appropriately activated. And then the last part of our brain that also activated with stress is dopamine. Now, dopamine does different things in our body. So we know that the one thing it does is that dopamine is our pleasure neurotransmitter. That everything pleasurable results in a spike of dopamine. So I have a little bit of chocolate, my dopamine levels go up a little bit. I have a cigarette, my dopamine levels go up a little bit more. I use heroin and I get a massive spike in my dopamine, and nothing will ever compare to that massive spike. So everything else becomes irrelevant, and I just want to use heroin. So dopamine, it's our feel good neurotransmitter. However, dopamine does other things in the body as well. And dopamine is involved in making things salient. And by salient, I mean that it's involved in making the relevant things in our environment relevant. So, it's the idea that um, when I'm doing an experiment that I've been, something I've been working on for a long time, and when it comes right, in that moment, I get this flood of feeling good. But that moment is also imprinted on me, and I'm able to focus and remember the details of that moment, and it's my dopamine being fired off, and things being relevant. An example of salience that I often give to my patients and my students, it's that when with dopamine and cannabis, a lot of people use cannabis these days. What cannabis does, it also obviously affects our dopamine levels, and people who use cannabis are often share their experience of being high. So when we're high, um, often we'll enjoy a cookie a lot, or we'll hear a particular song, and that particular song, in that moment, it feels so meaningful. But you listen to that song the next day, and it's just a song. And that's because in that moment, our dopamine levels are up, and things are appropriately, we focus on those things. So stress can be very good for us, right? And there's a sweet spot for stress. So if we've got too little stress, we get bored, we can be unmotivated. If we've got too much stress, we can feel overwhelmed, we can feel fatigued, we can make errors, we can even get burnout and depression. So there's a sweet spot to stress, an optimal spot to stress, and the what they call the flow state, and this is where the challenge and our ability are well matched. And it's the idea of when we're in the groove, when we're sitting working on that manuscript, and everything is just right. We're able to sit for hours and actually get things out. So that would be the optimal performance. Biologically, we were not designed to chronically be stressed. And I think, if you look at our evolution, our body systems kind of reset themselves outside of the stress. So the idea is that, when we sleep, we we kind of encode our memories, lay down our memories. When we sleep, our biological systems reset, and our cortisol decreases. So recovery is really important to us, and we shouldn't be chronically stressed. In the world we live in today, and with the different roles we all have, how many of us actually get to recover properly? How many of us, are juggling multiple things at any moment? How many people on at the airport are busy, marking papers, busy commenting on papers. When how many of us get home and have to prepare dinner, play with the kids while still finishing off our work? And I think that kind of stress our bodies aren't designed for. So when we have this chronic unresolved stress and when we have this lack of balance, our brain actually changes and our physiologically and psychologically there's changes to us. And warning signs that we should be looking out for is, our sleep changes when we sleep for shorter periods and wake up feeling unrefreshed. It's when we start working weekends and have difficulty disengaging. So we're working over weekends, and even when we're not working, we're thinking about work. It's when we start sacrificing the relationships in our life. When now our siblings can't get a hold of us because we're always at work, where our partner complains that we don't do anything together anymore. And in the state, we have this increased sense of perfectionism. We want to get things just right. And in the state, we have this false belief that working harder is going to resolve the problem. But we know that working harder is not going to resolve the problem, and that this chronic stress can lead to negative outcomes. So the negative outcome, if I use the gremlin metaphor, it's when, it's when that cute, cuddly, furry creature now transforms into this monster, but this monster is still caged in at work. It's still caged in a fixed environment, in an occupational environment. So this image, yeah, you've got these gremlins holding popcorn. They're in a movie theater. They're not out in the world. They're in the movie theater. And with burnout, it's an occupational syndrome. Okay. And burnout is something that doesn't filter through to other areas of our life. And with burnout, burnout is a triad of things. So there's three symptoms to burnout. There's emotional exhaustion, which is that feeling that we've got nothing left to give. That feeling where we just feel depleted all the time. We feel tired all the time. We're working, but we're feeling like we're not accomplishing anything. We don't feel sad. We don't feel depressed. We feel emotionally exhausted. Okay. The second symptom of burnout is that sense of cynicism or what we call depersonalization. So it's the idea that the work that we previously used to enjoy, the work that previously mattered to us, now feels meaningless. A student is just another student. A research participant is it's just a number now, and where we feel emotionally detached to the kind of work that we do. And then the last symptom of burnout is a sense of reduced professional efficacy. So even though we're experts in our field, even though we know we're good at what we do, we feel that we start feeling incompetent. We start feeling that, well, I'm not good at what I do. I'm not. I can't do the things that other people think I can do. And with reduced performance, our productivity fails. And so we take longer to write, we struggle to make decisions, and we find that our mistakes increase. So burnout is a syndrome. It does affect us, it affects our work life, but it shouldn't be trickling out and affecting our other parts of our lives in a severe way. Sometimes people progress from burnout into a clinical depression. Okay. And I think the word depression is used by different people in different ways. So, as lay people, we talk about depression as feeling sad. And normal sadness, the idea with normal sadness is that I only feel sad. I don't feel sad and I have this symptom and I have that symptom and I have that symptom. With normal sadness, I feel sad for a short time. So I might feel sad for a couple of hours. I might feel sad for a couple of days, but I don't feel sad every day, most of the day, for a long time. And a long time for us is 2 weeks or more. And with normal sadness or normal depression, I'm able to continue my roles and responsibilities in the same way, to the same quality that I usually do. So even though I'm feeling sad, I'm still the best parent, best employee, best friend that I've always been. Okay. So that's normal depression. We get worried when someone describes feeling different from the normal. They describe feeling this way every day, most of the day for a long time, where now they have a range of symptoms, a number of symptoms, and where they functioning, their roles and responsibilities get affected. So when we think of depression, when we explain depression, it's useful to think of depression as this tree that crops up. And in this tree, the symptoms are the branches of the tree, and the illness is actually the tree itself. And if you think about trees, they look different depending on the season. And with depression, it can look different in different people. It can look different with each depressive episode, but it's still depression. It's still the same kind of tree. And when we look at the branches of depression, we've got 9 symptoms and they differ. So when we're depressed, we need to either feel a joylessness or a sadness. Those are the core symptoms. So not everyone is weepy and crying all the time. For a lot of us, we feel joyless. The things that previously brought us joy now no longer bring us joy. The world is gray. Everything is just hues of grayness. And with that joylessness or depressed mood, we've got all these other branches. And for academic people and people involved in research, often the biggest branch is the cognitive branch. So depression can affect our cognition. When we're depressed, we struggle to focus. And because we're struggling to focus, we don't store information. And because we're not storing information, we don't remember things. We can't retrieve the information. So people are often inattentive and forgetful. When we're depressed, we struggle to multitask and switch between tasks. We often struggle to make simple decisions. And in people who are managers and being paid to make decisions, that can be quite a crippling symptom. And when we're depressed, we also work, we work much slower than usual. So there's a cognitive branch. And often I see people who come in and ask me about ADHD. And I need to explain to them that, with depression, we get a season of depression, and that in this season, I'm inattentive, but outside of the season, I'm my usual self. And that with an illness like ADHD, it's something that we have from childhood where the inattention is being there developmentally. And yes, it can get worse when we're depressed, but even when we're not depressed, we're still inattentive. So there's a branch of inattentiveness. When we're depressed, our sleep can change. So people sleep too much, some people sleep too little. Our appetite can change. Some people binge eat and eat a lot. Other people don't eat and lose weight. When we're depressed, we lose our sex drive. When we're depressed, our social bundles deplete quickly. So we don't want to see people. And when we do make the effort to see people, we get fed up really easily and just want to be on our own. When we're depressed, we get irritable. You know, we snappy with friends, we snappy with family. When we're depressed, we can think about death and dying. Okay. And it's a spectrum, right? So on the severe end, there's people who want to die, who have a plan to die. On the milder end, there's people who don't want to die. They don't have a plan to die, but the thought of not being alive is there. You know, if God was to take me in my sleep, it's not the worst thing that could happen. If I was to have an accident, it's not the worst thing that could happen. So all these symptoms are symptoms of depression. And it's important to call them depression because they are going to last a long time and they're causing significant impairment. So, you know, with a depressive episode, if we don't treat it properly, it will last anything from 3 months up to 18 months on average. And, you know, when we treat it properly, we obviously reducing the duration and we're reducing the amount of symptoms that someone feels. When we're depressed, all of us, doesn't matter who we are, we self-medicate. Yeah, so I mean, all of us, when we're ill, we don't rush to the doctor. We first try to do something ourselves. And what we find is that people self-medicate in ways that can end up being harmful. So, I didn't say part of depression is to feel pain, right? It's a symptom of depression. So there's people who don't have a physical cause for pain, but they feel pain. So typically headaches. There's other people who've got a physical cause for the pain, but when they're depressed, the pain feels worse. So a lot of people, when they're depressed, they start using pain tablets, especially the codeine-containing tablets, the Atcadols, the Myprodols, the Dolarols, you know, the ones with codeine. And with those, you know, they're addictive. And unfortunately, in this country, they're not scheduled in the way they should be, so they're freely available. So we often see people who've got an analgesic dependence. We also see people who drink too much and run into problems with alcohol, and we see people increasingly using cannabis and you know THC gummies that run into problem with the gummies. So self-medicating often goes hand in hand with depression. And for some people, it might be it might take over and become the beast that needs to be managed. And then with depression, you know, it often goes hand in hand with anxiety. And with anxiety, there's two big groups of symptoms. So there's a worry, which sits in our pit of our stomach, and you know, it's always there, it doesn't go away. And we just future think, okay, I'm not going to be okay, I'm not going to cope. And there's also panic. And the way to describe panic is that it's these waves that can come. So you get big waves, you get small waves, but they all have the same shape. They start off slowly, they build, they build, they build. And at some point, they're the worst they're going to be. And then they slowly go away. And, you know, it builds over at least not more than 20 minutes. So it will always peak within 20 minutes, but they can take hours to go away. And when it happens, there's always two sides, but the two sides are not equally matched necessarily. So there's a side of thoughts, of dread, I'm losing control, I'm not all right, I'm dying. And there's a flood of, of adrenaline, so we can get any physical symptoms. It can look like anything wrong in the body. So if we start from the top down, some people feel dizzy, some people feel underwater, some people might have blurred vision. We can sweat, we can have a dry mouth, we can shake, we can get pins and needles, chest pain, shortness of breath, palpitations. uh, stomach discomfort, lose bladder control, lose control of a limb. So in that moment, we can have any physical symptoms, but the idea is that those symptoms come with this thought of dread and they come in a wave-like pattern. So stress can ultimately lead up to depression. Chronic stress can ultimately lead up to depression. But it's important to say it's depression and not, let's say, it's burnout. I think that working in mental health, it it's stigma, and no one wants to have a mental health diagnosis. No one wants to have any diagnosis. But for many of us, it's more acceptable for us to say I'm burnt out than to say I'm struggling with depression. But often the people I see are coming to me because they're actually depressed. And I have to say to them, let's treat this properly. So, what does treating properly look like? So, you know, firstly, it's about acknowledging that I'm not okay and saying, okay, I need to go get help. Where do I go get help? So, I would recommend either a GP. GPs are all trained in mental health. All of us, so all doctors can do the basics, the first line treatments of mental health. And the advantage of GPs is that they're able to exclude medical things that can cause mental health problems and medical things that can masquerade as mental health problems. So a GP is a good first call. Some people can also go to a psychologist, and a psychologist is also a good first call. So it's either or. So with psychologists, there's different kinds of psychologists. I think let me start there. A lot of us don't know that. So with psychologists, they, are, they work in a similar way to accountants, right? So if you're doing your accounts, you can go to a bookkeeper who can do basic bookkeeping, or if it's something very complex and something large scale, you can go to a chartered accountant. Everyone can do basic books, but not everyone can do the complexity. So with psychologists, you get counseling psychologists who are very good at the here and now things. So the short term things like grief, trauma. You get clinical psychologists who are the experts in the talk therapy, and they help us look at our past to see how our past is shaping our present and help us plan for the future. So psychologists, first port of call can be a counseling psychologist. There's a lot more counseling psychologists available than there are clinical psychologists. And a good counseling psychologist would be able to say, well, this is beyond my scope of practice. I think you should be seeing a GP or a clinical psychologist. Um, I must mention the term therapist and how I fit in as a psychiatrist. So in mental health, every single professional that works in mental health is called a therapist. We're all able to do basic supportive therapy. How we differ is in terms of our training and our focus. So as a psychiatrist, I'm a medical doctor first, so I'm a GP first, and I've gone on to specialize in mental health. As a psychiatrist, I see people who lie on the more moderate to severe end of whatever illness they have. And someone who's on a mild to moderate illness can typically just see a psychologist. And as a psychiatrist, my expertise is on managing medications. And whilst I do the basic forms of therapy as well. And so what we're good at is that, and if I use a swimming example, if someone is drowning, and 30%. A psychiatrist is very good at getting you from 30% to 60%. If you are at 60% and you want to get to 80%, if you're already water safe, but now you want to learn to scuba dive and windsurf, you go to a psychologist. That's the person who takes us up to our optimum. Okay? So a psychiatrist, we should never be first line, and we should always be, seeing people that are referred up to us because there's so few. And then my last point on this talk is just around the role of the employer. With burnout, it's an occupational category. So in managing burnout, it has to be managed in the workplace. And, it's about realistic demands, realistic breaks, and realistic targets. And with that, there has to be a conversation with the employees. And I think that for all of us in academia and for all of us as people, we must question ourselves is that, are we acknowledging burnout adequately? Are we taking the time to recover? And also for those of us who are managing people and working with people, are we complicit in this chronic stress? Are we complicit in having unrealistic demands of people? So, yeah, let me stop there and just get some thoughts.
Oh, wow. Thank you, Dr. Qhama, for this interesting presentation. Yeah, that was awesome, and yeah, it made me think about my day by day, like how I can manage the stress and depression. So yeah, now I would like to open the floor for questions, comments. Yes, Prof.
Thank you very much, Dr. Qhama. That was a very good talk. And can you hear me?
Yes, I can hear you.
Okay, so the talk was quite interesting and partly very scary because it seems to me that all the students and staff members in my group are all depressed. If the signs I'm seeing are correct, I'm not a clinical psychologist. I've got a couple of questions. One will be directed towards institutional policies, especially when obviously certain institutional policies are definitely going to drive people towards depression, extreme stress and depression. The second question would be around some of the signs we see. I'll use my case as an example. I think for an odd 1.5 decade, I don't know how short is short sleep, but my sleep has been short. So does that mean I've been depressed for 15, 20 years? Are there other things that could cause short sleep? I don't have some of the other symptoms you mentioned, but short sleep is absolutely there and has been there. I get deep short sleep and I feel very good. Is that a sign of anything that I have to worry about? On the policy side, to be honest, in all workplaces, I'm non-South African, by the way. So I arrived here in 2017, worked for the South African Radio Astronomy Observatory 2017 and 2018 as commissioning scientist. And then NW for 5 years, and now UNISA for the past 3 years plus a small fraction. What I've seen in these 3 places, if I have to compare the work environment and work policy, I would not use the term toxic so that we don't get into a different debate. But the policies seems to, I can mention specific, let me use UNISA as an example. The targets, what postdocs are required to produce in 1 year is completely unrealistic at UNISA. So is there a bridge between people like you who speak about stress? I know recently UNISA has had somebody who has said 3 staff members who died were because people who mark scripts were removed. and replaced with academic associate. Therefore, the stress levels and the work people have to do, the staff members have to do increase. And there has been 4 staff members who passed away in gap of just their deaths separated by 1 week each. Of course, we don't have any evidence to either show that this is because of a change in policy of the university to convert people who mark scripts to adjunct academics, as they are called. But someone has alleged that.
You, Prof. Let me interrupt you, because otherwise I'm going to lose track of the different strands of a question. So I think for me, you're asking 3 different questions. So you're asking, what is a diagnosis versus what is a symptom? And then you're asking specifically around sleep as a symptom. And then you're asking around the role of the institution and the aims and goals of institutions. So in mental health, I think as a psychiatrist, we don't diagnose. We spend a lot of time normalizing things for people. And the idea for us is that any diagnosis, it needs to be typically a change from normal for that individual for depression. So with depression, I'm not always depressed. I'm able to say that actually in December, I was fine. In last June, I was fine, but now something is different. Yeah, so it's a change from normal. It's feeling this way every day, most of the day. So I'm not depressed today and then I'm fine tomorrow. I'm not depressed for a couple of hours and then I'm fine the rest of the day. I feel this way every day, most of the day for more than 2 weeks. And the core symptom must be there, which is joylessness or depressed mood. But we need another amount of symptoms. So, it's about groups of symptoms. So to diagnose depression, we need 4 out of 9 possible symptoms. And so one symptom doesn't make a diagnosis. And some symptoms, even if it's a collection of them, if there's no core symptom, it's not a diagnosis. So symptoms like sleep, appetite, attention, those symptoms are very non-specific and they'll occur in every psychiatric disorder. Whatever we have, whether we're using substances, anxious, have a dementing illness, depressed, we'll always struggle with attention. So the symptom of inattention is not specific. It's about what else goes with it. And so when we diagnose, it's that change from normal. It's there every day. It's a collection of symptoms, and it must impact. It must impair me. So if I've got all these symptoms and they're not causing distress or impairment, then it's not a diagnosis.
Okay.
Then we don't label things unnecessarily. So that's how we'd come up to a diagnosis. And with sleep specifically, if you look at sleep is like weight or height or complexion. It's everything. It's a grade. So there's a fallacy about the correct number of hours to sleep, and that's not true. There's a spectrum of things. So when we look at sleep, we know that our sleep changes the older we get. A newborn baby is going to sleep most of the day. Once we hit 60, we're going to struggle and not need to sleep, but we're going to be frustrated because we're awake at night when everyone else is sleeping. So our body doesn't need the sleep, but because society's, the way our days are structured, I don't want to be awake at 4 o'clock because I have nothing to do. So with sleep, we only get worried if the person is fatigued. If you come to me and say, you know what, the way I'm sleeping, I'm tired the next day, I'm not able to perform the next day, then it's a problem. But if you sleep 4 hours every day, and you've been sleeping 4 hours every day for your life, and your functioning is not impaired, there's nothing wrong with that. That's how you are.
Yeah.
And then the last question was just around the institutional policies. Like, for me, it's a personal experience, but what struck me in my experience is that we often don't understand the aims of institutions, and we mix things when it comes to institutions. So UNISA's primary role is not people welfare. UNISA's primary role is outputs, be they research outputs, be they graduates. And I mean, most universities, it's weighted around research, right? And research is the main thing. Teaching, yeah, maybe. Admin, definitely not. The but that's what they want. That's what the university wants. And I think that it's I personally think it's wrong when we want to make the university responsible for people welfare. I think what happens is that managers get stuck in between because managers are expected by the university to produce the outcome and they're expected to manage the people. And I think it's difficult for managers and then becomes important for the individual to understand that they need to prioritize themselves, that it's not for the manager or the university. They need to prioritize their own welfare. And I think it's always going to be that push-pull relationship. Um, and I think a good manager understands that, and a good manager should be able to, in the ideal world, balance those two things. Um, yeah, so I don't know if I
Yeah,
answered you
you did.
correctly, bro.
Yes, you did. Thank you very much. I'll give others the opportunity to ask questions. Thank you very much.
So you can go ahead.
Okay. Thank you, Chair. My question is a general question, Doc. So, is there a cheaper way to get help? Because most of the solutions that you mentioned cost money, and money is one of the leading causes of stress. Because visiting a GP, it's not for free.
Yes.
Thank you.
So, okay. First thing, right, is prevention's always better than cure. So I think the understanding and the importance of rest and recovery to prevent, that's number one. When we've reached the point where we can't prevent and we need to do something about it, I think it's important to be knowledgeable about resources in our system, right? So a lot of universities would have mental health services, let's say. And some universities would, and some departments within universities might have their own resources that are different. And typically those resources would be short term and there'd be counseling psychologists. That's the most available thing. So I'd say to you, ask around what's available through UNISA itself. Outside of that, I would say that, we in South Africa have a government service, right? And if you look at how government services are structured, it's that we've got clinics which feed into hospitals, which feed into specialist hospitals. And at the clinic level, we've got nurses who screen and who are able to screen and pick up things. And even at the clinic level, we've got general practitioners, GPs. And all GPs know about depression and anxiety and can treat the bulk of depression and anxiety with medications, right? There's few psychological services available in state, but depending on the area, you can find that there are some psychologists. And then for some people, they've got medical aid. It's not many people, but some people do. And with medical aids, we often don't know how they're structured around mental health. So with medical aids, you get what they call PMB conditions. So PMB, what does it stand for? Okay. Essentially, there's 250 diagnoses where if we've got one of those diagnoses, the medical aid needs to give us additional benefits. And so for depression, for mental health, depression is one of those diagnoses. And what that means is that if I'm depressed and I apply and I say to my medical aid, I need treatment for depression, what they will do is that they'll give me 15 sessions each year with a clinical psychologist or a psychiatrist. And that will come from outside of my savings. Okay, so I'll have my normal 10,000 Rand annual savings, but a PMB benefit, if I apply, it would be that I can access 15 sessions with a psychologist as an outpatient, or if I need to see a psychiatrist, access 15 sessions with a psychiatrist. So those benefits are there.
Sorry,
as
Doc,
part of
is
the
the
medical.
PMB prescribed minimum benefits? Sorry for cutting.
Yes,
Okay.
yes.
All right.
So I don't know if that helps, Khathatsa.
Yeah, I think it helps. And I agree with you when you say it also depends on the area, because where I'm from, the clinics around there, they don't have GPs like you stated. But I get your point. Thank you.
Okay, thank you. Sim.
Okay, no, thank you so much. Thanks again, Doc. I actually want to. I have two things. One is more of a question, and one is more of like a comment, or I don't know, maybe a lead to open discussion. So, I was just laughing when James is mentioning about the short sleep because it's been a thing also for me. But I think what I want to ask specifically is that, first of all, maybe let me say it this way. I struggle to sleep during the day. I don't know if that is a problem, but even if I'm tired, I just struggle completely to sleep during the day. So now this is what happened. Sometimes I have to work overnight and then I don't get to sleep at all. And I feel fresh, I feel okay. And then I don't get to sleep during the day because I can't sleep during the day. But I'm tired. But my body just doesn't want to allow me to sleep. So, and I remember vividly, not so long, I actually spent 2 days literally of not sleeping like this. Like maybe I'll be just like 30 minutes and then I'm up and then go again. I'm trying to understand that because I've been worried about this thing. Yeah. And then the second thing is I know because obviously at UC, in fact, I just came from UCT, I joined UNISA. So I know at UCT in the department, maybe this one is also directed to people like James and everyone else heading the department. There are actually this kind of regular meeting, more special for students. And I'm going to talk for us as a the university, the department at this point, because I know that this is the issue for everyone else. But specifically from the department point of view, I know that UCT, I don't want to say there is an affiliation but I know they work hand in hand with people like you. So they normally visit and they will be like, just the day where we talk about mental health, they visit different departments of your based on the schedule and stuff like that. I'm not so sure, obvious, how you end up giving this talk, but I would like to hear more about, avenues like that. Will there be any case maybe where we can just link up? Because I'm just thinking now we are growing, we have students coming, they will need this kind of help.
Okay.
Yeah.
So I'll start with the second question first. I think that when we train doctors or train any mental health professionals, there's different roles to being a doctor. So as a doctor, we're clinicians, yes, but we're not just talking illness and disease. We also educators, we also health promoters, we also need to understand management and finance. And I think if the department wants to get people to speak, I would say to them, approach any university department and you would find someone or group of people who want to speak. Because for all universities, I know that one of the ways that individuals are assessed, it's around cross university collaborations. It's around the public health kind of things. So that would be the easiest thing to do, I would say, to try form a link with a different university department. I think when it comes to sleep, your question around sleep. So there's this concept of sleep hygiene. So there's the sleep hygiene is the behavioral things that we can do to improve our sleep. And it's a number of points. So the first thing is that we want to be regular with our sleep. Doesn't matter what time we sleep, as long as it's more or less the same time. So if midnight, it's midnight, more or less around midnight most nights. We want to sleep in one chunk. So we don't want to nap. Napping is bad. 10 minutes, 20 minutes, any naps are bad. Okay? Because we need to build up our sleep credits. And every time we nap, we're losing those sleep credits. So we don't want to nap. If you don't sleep the day before and you're tired, bank the sleep for nighttime. Don't nap. Okay? We also want to avoid things that can interfere with our sleep, substances. And the most common substance is caffeine. So for a lot of people, they don't understand that coffee can last up to 15 hours in our body. And caffeine interrupts the architecture of our sleep. So we might sleep, but we won't get into a deep sleep. And also we might struggle to fall asleep. So if any coffee after 1 o'clock or any energy drink after 1 o'clock is bad. And then we want to exercise. And by exercise, it's, walking 20 to 30 minutes 3 times a week, a brisk walk. And then screen time, that's another devil. So, we need to be putting away screens for at least 30 minutes before we get into bed so we can actually get our minds to decompress. And I think for most people, when they struggle to sleep, it's a combination of one of those or of a couple of those things. And getting those right can change the sleep. And,
okay. No, thank you.
And obviously, it's it's normal not to have a few bad nights of sleep, right? Not sleeping well once in the blue moon, that's okay. It's when it's every day, most of the time, that's when we get worried.
No, thank you so much. I think I understand why caffeine, because I normally take a cup of coffee and then I just go over. But yeah, no, thank you so much. Yeah.
Okay.
Yeah, just to comment quickly before Prof. Kress goes. Yes, the university does have people to speak to about mental health and all those. I just quickly checked my email, put in mental health and searched, and it pulled out so many of the emails. So sometimes they advertise this on what they call INTCOM, internal communications. So maybe that's something to take advantage of. I've never been to any of the talks, but yeah, it does exist.
And Prof, can I ask, is there like an ICAS system? So, companies would have a short-term psychological support for students or employees. Does UNISA have such a thing?
I would need to inquire so I don't give the wrong answer, but none of my students has ever received any form of support of that nature. Maybe the students know better than I do. But some of the talks on mental health here were directly mentioned students, they targeted students. I don't know how regular they are. Yes, so there may also not be. If anyone knows better, please feel free to comment. Yeah.
I see another hand up.
Yeah, I mean, what I do know at UNISA is there is a clinic on campus in Florida, which can deal with various sort of primary healthcare issues. So that might be a place to start at least. Yeah, thanks for the talk. I was just wondering, the one university I taught at, it was revealed that over 70% of the undergraduates were on antidepressant medication. And I'm kind of wondering, what's your feeling about antidepressant medication? I mean, presumably it doesn't always work. Does it work often enough that, all the prescriptions are justified? Can yeah, just what are your thoughts on antidepressant medication?
So I think the challenge with mental health is that we kind of lump everything into one thing. And, I think the a lot of us kind of think of mental health medications as one group, and a lot of us think as mental health diagnoses as one group. So with antidepressants particularly, antidepressants have an evidence base for major depressive disorder or major depressive episodes. Okay. They don't treat symptoms that are depression-like. So if I don't have a diagnosable major depressive episode, if I've got depression-like symptoms, there's no evidence base for that. And so that will be the first thing. And then when we use antidepressants, our decision to use them is based on severity of illness. So if I've got mild to moderate depression, judging on how many symptoms I have and judging on how distressed I am and judging on how functionally impaired I am, so it's gray, it's shades of gray. If I've got mild to moderate depression, therapy is as effective as medications. And therapies and medications have pros and cons. So therapy is useful because it's going to help us think differently around the things that are stressing us, and it's going to help us to prevent future stresses. Therapy is expensive in terms of cost. So, a session of therapy is going to cost around 800 Rand at the cheapest. And we might have to go for, a number of months. And it's costly in terms of time. I need to invest the time to go to therapy. Okay? But the advantage of therapy is also that it works fast. So people get better from the first therapy session. Antidepressants are effective for moderate to severe illness. The upside of antidepressants is that, they're cheap compared to therapy. So, and our first line antidepressants, a month, they're going to cost about 100 Rand in private. In the state, it's even cheaper. Yeah. The advantage, obviously, is that we take a pill. We don't have to go sit for therapy. The disadvantage is going to be that antidepressants don't work immediately. So they work like exercise. So if you want to get fit, you need to exercise every day. You need to exercise for long enough. So any fitness program, it's 6 to 12 weeks long. And for antidepressants, our units of measurement time-wise is a month. In the first month, we don't expect big changes. And it's only after a month that we start seeing things. So they take time, and people don't want to wait for that time. And obviously, if we put it in our mouth, we can get side effects. And depending on the kind of side effect, depending on the kind of medication, we'll get side effects. When we look at all our antidepressants, there's no best one. We've got 10 classes. There's no best class. They all work equally badly or equally as well. So we know that 1 in 3 people will get better on any antidepressant we try. And we often have to keep trying different ones to find the right one. Where we are right now in the state of medicine, we've got genetic tests which will tell us which medication you're less likely to respond to, but they're not necessarily going to tell us which one you will respond to. And often it is a hit and miss. So I'm going roundabout way to answer your question, but I think that antidepressants, when a proper diagnosis is made, they work. But if the diagnosis is loose, they don't work. And then antidepressants don't work for everyone, not the first line treatments. Yeah, I don't know if I covered it. Okay.
Okay.
From Sivu.
Oh, okay. Sorry, I had to use a different microphone. No, for me, it's just a quick one out of curiosity. How do you, for people that are doing well with their research and everything, and their output is still fine, can you how do they say that they may be clinically depressed or something?
That's a good question. So the experience of depression is like, the example I give, it's like someone running on sand versus someone running on the pavement on tar, right? You're gonna run the same distance. You're gonna run 5 kilometers, and someone looking from the outside will see you finish 5 kilometers. But subjectively, you know the effort that you're putting in is very different. So with people that are high functioning, on the outside, no one can see the changes in the outputs, but internally, subjectively, we know that we're putting in significantly more effort than we need to. And when you speak to a professional, as much as we're functioning in the work life, you might find that the symptoms are presenting themselves outside. So what am I like when I'm at home? Am I snappy with my wife, snappy with my kids? Am I isolating myself? Am I not sleeping? Am I struggling to focus and taking longer to do the things that I need to do, but I'm still doing them? So I think it's not one thing that makes a diagnosis. And as clinicians, what we trained in, it's pattern recognition. It's understanding the different patterns that then go into making a diagnosis. The role of therapy, I want to add here. So I see a therapist. I have a therapist. I see them every 2 weeks to every month. And the things I take to therapy are, yes, some of it is work supervision, but a lot of it's my own personal life. And I don't go to therapy because I'm struggling right now. I go to therapy to optimize. So a good therapist helps to prevent, but they also take us from being 60% to optimizing. And the vast majority of psychologists are seeing people to help them to optimize. It's not only around illness. And I think we must change that narrative around what a therapist does. And it's not only when we're drowning, it's also to help us, branch out and do the new scary things.
But just to say the last words, thank you, Dr. Qhama, for availing yourself to give this presentation, even if you're not part of astrophysics and space sciences. I found it very useful for everyone to have this kind of talks, to have like a awareness of health. So, but thank you to Professor James, who allowed to invite you to give a talk. So, yeah.
Well, thank you for having me, guys. Thank you.
Yeah, thank you so much, Doctor.
Thank you.
Have a good afternoon.
Thank you. Thank you so much.
Thank you, Dr. Bye.